today's webinar, The Humanism Pocket Tool, Finding the Joy in Treating Challenging Patients. I'm Caroline Gumpenberger, and I will be the moderator for the webinar, presented by the National Healthcare for the Homeless Council, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation, with the last 10 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenters for written responses after the webinar. If you're having technical issues, you may also call Julia Dobbins at the Council's office at 615-226-2292, extension 232 for assistance. Our presenters today are Andrew Shaner, Psychiatry at UCLA and the Greater Los Angeles VA, Lillian Gelberg, Family Medicine at UCLA and the Greater Los Angeles VA, Kristin Kopelson, Nurse Practitioner, Greater Los Angeles VA, and Carole Warde, Internal Medicine, UCLA, Greater Los Angeles VA. And now we'll pass it over to Andrew.
Well, good afternoon, everybody. You might hear some awkward pauses, as I imagine there's people who are going to say something, but we actually can't hear anything you say. So let me start it off. I'm here with my colleagues who were just introduced. You saw Michael So on the earlier slide. He's in charge of medical education for our team, but he just had a new baby, so he's not with us today. And then on this slide is a list of this larger group of people that have worked on the Humanism Pocket Tool with us. Let me take a peek at the next slide. The purpose of this session is to help you understand a tool that we've developed. I'm going to go back to the previous slide for a moment because I want to say something a little bit more about the context. We are all clinicians and faculty members within a clinic at the VA that focuses exclusively on homeless veterans, and in concert with a vast program of social work and housing support for them. It's an interprofessional clinic, so we have internal medicine, nurse practitioners, psychiatry, psychology, social work, RNs, LVNs, pharmacists, and we are also a teaching program. We also we're funded to have trainees from most of those professions working together. We have maybe 27 of them at this point, 35 now. So, and we teach them how to work together as interprofessional teams. And it's in that context that we developed the Humanism Pocket Tool that we're going to talk about today. Let me see if my colleagues have anything more they want to add in terms of introduction.
I think that this Humanism Pocket Tool began, we were asked when we got our grant to develop a scholarly project, and this really became our scholarly project early on. It certainly evolved over the course of the 3 years, but it really began kind of as a mandate from our grant. We've also found that as we've gotten along, it's helped the culture of our clinic so much. It's really one of the foundational interventions that we do to keep our culture relationship-centered and respectful.
That was Carole Warde, by the way. Anything else? Okay, so here are the learning objectives. Explain how inborn automatic emotional responses, especially to underserved patient populations, can sneak up on clinicians. List and describe 7 techniques to help us adjust these responses and stay humanistic. And create and use a brief, vivid description of a patient. Before we get into that, let's talk about driving to help us get into the framework of humanism. I assume you all drove to work today. Many of you may have encountered situations a little bit like the one I'm going to describe, but let's go. Imagine driving to work on the freeway in moderate traffic. In your rearview mirror, you spot a car approaching rapidly before tailgating your car. Just as you are about to change lanes, the car zooms past on your right, then swerves back in front of you, and repeats this with the cars in front of you until it is out of view. What are your immediate thoughts about the driver? If you like, type your first thoughts in the chat window or just jot them down on paper in front of you. We'll give you a moment to do that. Let's see. What a jerk.
That's what I say.
Not thinking clearly, nuts. We're waiting for more responses.
Some you may not want to type.
Probably in a hurry. Interesting. Inconsiderate. Move and move over fast. This guy is crazy. Impatient. Who gave this fool a license? I like that. They must be in an emergency. All right, let me move on now, because we're now beyond immediate thoughts. People have had time to think a little bit further. All right. Why do you think he's driving this way? Well, we've had some responses to that. Did you wish a police officer had seen it? All right, moving on. Your carpool partner sitting next to you says, guess he feels he's more important than the rest of us. You start to imagine other stories about the driver and his or her circumstances that might explain the speeding and swerving. What can you come up with now? How does each different story affect your feelings towards the driver? We'll give you a chance to respond to those. Let me go back to that slide. So now let's see. Oh, I have to scroll. Hang on a second. They must be in an emergency. I would be startled and my heart would be pounding. Pray he didn't connect. Yes, I wish police also. I'm going a little bit further. He may have a health issue or a sick family member. Maybe somebody is having a baby. Pregnant lady in the car. Worried for the other driver. The driver has had a long history of similar experiences.
Behavioral health crisis or untreated.
Oh, yeah, yep. Okay. All right. So, now let's move on. Later that day, your carpool partner looks up from her phone and says, listen to this. A malfunction aboard an experimental driverless vehicle sent it careening through rush hour traffic for several minutes until a technician on board managed to regain control. That has to be the same car we saw. Now that you know there was no driver responsible for the speeding and swerving, how do you feel about the event? The machines are taking over like in Terminator.
And I feel like a jerk.
Let's see, there's more here. Let's see if we can get to it. I'm never getting into one of those cars. Confused. Why would they put it? Why they would like? I guess you have to click to expand it. Now we're having trouble with it. We'll just leave it alone.
There you go.
Not happy with the company who's responsible. Glad nobody got hurt. All right. All right. So, what do you imagine engineers and technicians will do to keep this from happening again? All right. Now let's just summarize and how it relates to patient care. When we first encounter a patient or client or simply a person whose behavior angers us, our brains automatically invent stories about the patient that make him responsible and paint him in a bad light. Given time and further questioning, we often discover other explanations, akin to the driver speeding to see her injured child. Taken still further, when we see all of a patient's behavior as products of a very complex biological machine, we no longer have anyone to blame. Instead, we have a suffering patient, mechanisms to understand, and problems to solve. Okay, let's now get your thoughts about actual patient care. Click yes if in the last month a patient was angry with you. I think we all get to see the responses here. Oh, I see, it's going to total. 17 people said yeah, oh, now 25. Moving rapidly. I guess we can all see it.
Mm-hmm.
Does it say how many total people are on?
Yeah.
101 people are on right now, so that's quite close to it right there. And it's looking like 80%. All right, let me move this out of the way.
So this is a pretty common thing.
I want to move this pod out of the way. I can't see. Oh, very nice. How about in the last month, you were angry with a patient?
Yes. This is whether you shared any knowledge of that anger with the patient or not, right? So this is
yes,
internal.
Yes.
Internally
Internally angry. That's a good, thank you, Kristin. This is internally angry, not necessarily expressing it. Still pretty high numbers. We had 80%, patients angry at you and 70% feeling anger towards the patient.
Caroline, will you tell us when we should stop the question and when we should keep going?
Well, we can just do it now, I think. Yeah. There we go. Now, how about in the past month? Say yes if a patient who had been angry with you previously or with whom you had been angry gave you a hug or some other expression of gratitude.
Mm-hmm.
Wow.
That's why we do this work.
Isn't that interesting?
People are thinking a little longer on this one. I did. I got a hug a couple times this month. I just got one, but I
Really?
never angry.
Ah, yes, you have to add that. Yeah. Well, these are very high numbers too. Look at that.
Yeah.
Well, okay. Maybe we're bringing coals to Newcastle here, but these three questions capture in a nutshell, the kind of problem the Humanism Pocket Tool is designed to mitigate and the kind of outcomes we have in mind. Okay. Now, think of a patient or client who evoked anger, frustration, disgust, or contempt in you. Jot down the emotion you felt and what provoked it, how that emotion affected care, what you did to manage that emotion, and maybe how you described the patient to colleagues or in the ID section of progress notes. Take a few minutes to think about this and jot it down, and we will get back to you. And of course, you could, if you can describe some of that in the chat box, go right ahead.
Turn the volume.
Turn the volume up. Hannah, we have a response that they are having trouble hearing us. Maybe that would help. I'll move that. That's as far as it's going to go, people. Okay.
I felt irritated, especially in the majority of those.
All right. You know, oh, here it is. Oh, I want to see my notes. So I was looking through the chat box, but I think what I'm going to do is just tell you about something I encountered last week as an example. I was annoyed briefly last week when a patient asked me to write a letter indicating that his newly diagnosed sleep apnea was due to his post-traumatic stress disorder. He hoped this would help his VA disability income. He also wanted me to indicate that he was, quote, as likely as not, that the sleep apnea was as likely as not due to the PTSD. I knew there was some association with PTSD, but I had just written a letter last month with respect to his claim, and this seemed a bit pushy, so I was annoyed. That's a minor example, but it's the kind of thing that we're talking about here. Okay. All right, moving on. On this slide is the front and back side of the Humanism Pocket Tool. It is actually on a roughly 4 by 5 inch card, and we print these and supply them. And on this presentation and on the back of the card, there's a way for you to contact us and get copies of the card. We just need to know how many you want and what your mailing address is. Of course, you might want to listen to the rest of the seminar and see if you want it, but I wanted to point that out now. And we're now going to review the card with you in as brief a fashion as we can. I want to begin with the concept behind the card, which is this. Your brain is equipped with inborn automatic emotional responses biased to protect you from people who might be dangerous, infectious, or time-consuming. These emotions can sneak up on you. Use the following techniques to adjust your brain and stay humanistic. Just briefly, humans have an extensive suite of emotions that help us form complex cooperative relationships, leading to highly effective teams, tribes, and nations. The emotions that promote caring for others can be exploited by others, so this suite of emotion also includes emotions designed to protect us from such people. We aren't perfect at detecting such people, so the detectors are set so that all the errors have to do with detecting a problem when there is none. This is just like your smoke detectors. Every real fire will trigger them and save your life, but they might also sound when you burn the toast. Often the anger, fear, disgust, or contempt we feel for some patients is just our own threat detectors responding to the interpersonal equivalent of burned toast. The Humanism Pocket Tool helps you manage your threat detectors so that you can be both safe and humanistic. The HPT has 7 tools. They are coach yourself towards a caring frame of mind, be warm, listen actively, create a vivid vignette, use the vivid vignette with other professionals to inspire and coordinate care. During interprofessional meetings, listen actively and appreciate differences, and know your colleagues as people. Lillian, take it from there with tool technique number 1.
Okay, so coach yourself toward a caring frame of mind. For example, tell yourself, I may be frustrated and I can choose compassion. Or, Mr. Smith is not himself today. Or, I've got a strong and compassionate team, which we'll tell you more about in items 5, 6, and 7 on the back of the card.
You want to add anything to that, Lillian?
Yeah, this evolved in our team meetings, and it was an absolute amazing experience of interprofessionalism where us primary care providers didn't quite have as many toolkits in this area as the psychologist and the social worker did, who came up with what they use when they go into difficult cases and how they coach themselves before they go in, or even in the middle of a difficult session. And we've all been, utilizing these now, and it's been very helpful.
But I learned Mr. Smith is not himself today from an LVN who has since moved on.
Right.
Okay, Kristin.
All right, this is Kristin. Number 2 is be warm. Use your nonverbal behavior, tone of voice, physical proximity, touch, and mirroring patient movements to reassure a patient that you are not angry, frightened, or disgusted. Begin by comparing your behavior in warm professional relationships with your behavior with challenging patients. Then adjust your behavior with patients in the warm direction. Something I try to do is welcome each patient as I greet them like they're coming into my home, make them really feel invited in and that I'm happy to see them. And in the case where I don't necessarily feel that straight away, I try to identify that early and see the patient in a new, fresh light every time. So try being warm and see how it goes the next time. I had a patient a week or 2 ago who had just gotten some publicity and some negative social media stuff. He happened to be involved with a musician who was in the news for some bad behavior, and this patient came in and said, are you mad at me? I said, of course not. We don't judge here, and you and I have a good relationship, and I judge you for the person you've been with me. So that's one example of, him being associating himself with this bad behavior, and many people were, but in this place, he's in a safe place.
Carole.
Okay, listen actively and be curious. So in doing this, you begin with the question like, well, what brings you here today? And for 3 to 5 minutes, you actively listen. You may use statements that are open-ended questions to get them to share what they're thinking. Use minimal encouragements for them to continue. If they're stuck, you can maybe restate what they just said, and then you can use your empathy and remark at certain points. Now, lots of us have heard about active listening and to be curious, but it's always a lot easier said than done. Especially if you're in the room with the computer or something, you feel like you have to start writing or doing something else. But if you think of yourself in a conversation and how wonderful it feels when somebody's looking right at you and they're paying attention and they're not distracted, that we certainly owe this to our patients. Now, the 3 to 5 minutes for primary care physicians, all the trainees always go, 3 to 5 minutes. I don't have time for that. Well, it might not even take 3 to 5 minutes. It might take a minute or 2. But I think the point is, when you demonstrate to the patient that you really care about what they're saying and you connect with them, the interview will go, much quicker, and they're much more likely to share what's really going on in their heart.
All right, let's move on to this vivid vignette. And so skill number 4 is create a vivid vignette. To discover the patient's aspirations and obstacles, use active listening and questions such as, what matters to you? What brings you joy? Or what gets in the way of you attaining your goals? Distill this information into a vivid vignette such as 35-year-old Marine Corps veteran studying to be a pastor but haunted by an Iraqi torture chamber and struggling with PTSD, diabetes, and methamphetamine abuse. Tell the patient how you will use the vignette. Read the vignette to the patient and ask what changes you should make. The vignette reassures the patient that you see him or her as a person, not simply a diagnosis. Here's a couple of other ideas about creating a vivid vignette. I sometimes say at an appropriate point, suppose several months from now the pain is much better and you have your own apartment. What do you see yourself doing that you would find meaningful and enjoyable? What matters to you? Follow up using listening responses only. Use empathic remarks here too, but with respect to positive emotions. For example, a patient beams at the thought of returning to his artwork and you say, you'd love to be known as the artist, not the addict. Use what you learned to identify important aspirations and obstacles. Get the patient's input on the vivid vignette you've created, perhaps with a statement like this. Our team will meet frequently to discuss how to help you. I want to make sure everybody knows who I'm talking about when I bring up your name. I'm thinking of introducing you as follows. What do you think? It's been amazing what patients say when you take this kind of time to develop a way of introducing them to colleagues. Responses I hear all the time are, well, nobody's ever asked me that. Wow, I never thought of it that way. And many people have commented that it seems to mark a turning point in the relationship with a patient. My colleagues are nodding their heads at this.
Yeah, it's really the question I like to ask is, it's a dream question. It's so, if everything goes well for you as you're planning, where do you see yourself in a year? Pie is the sky. Where do you see yourself? And oftentimes the patients will look at me in wonder, like, nobody's ever asked me that question. And it's really nice to see, you can just see their face light up when they start to think about this.
Here's a few examples from our program. 26-year-old aspiring actor who panics during social situations. 29-year-old working to complete a bachelor's degree in business but struggling with obstructive sleep apnea and prescription opiate dependence, now on methadone. 38-year-old who studied criminology but is now convinced she is trapped in a fake version of America while being eaten alive by parasites. 55-year-old who dreams of fishing with a dog by his side but struggles to care for his demented mother while managing his own obesity, hypertension, and prescription opioid abuse. Yeah, go ahead.
So during our team meetings, when we present the patients or our huddles, when we present the patient using this vivid vignette, it just totally changes the conversation about these patients, totally changes how you look at them and how you discuss what their treatment plan is going to be. It's a lot better than saying, I got a 55-year-old obese, hypertensive, opioid addict who's here today. I mean, it creates the compassion and the care that we're supposed to be giving.
And that's what's on the next slide.
Oh, sorry.
Okay, Lillian, this is yours.
Okay. So this one, Carole has given us a little head start on. Use the vivid vignette with other professionals to inspire and coordinate care. So refer to the patient using the vivid vignette in discussions with colleagues and in the ID or summary section of progress notes. This helps you and your colleagues to see the patient more vividly. At one perspective as the primary care provider, but the social worker or the psychologist or the psychiatrist or even the pharmacist
technical difficulties, and we'll be back very shortly.
Are we?
Andrew and team?
Yes.
Yes.
Hi, so I've muted the presentation for now. We're having some issues with the sound. It looks like it's coming in and out. How's your all's internet connection?
How is our internet?
Our internet connection is great, but the sound is coming through the telephone.
Right, but this is a voice over IP
Yes, it
line,
is.
so it's
So internet
actually
looks great.
maintained through the
Maybe,
internet.
could it possibly, there's a fan above me, maybe it's,
I'm hardwired in. Yeah.
Can you hear
what
us
if
fine?
what if we took it off speaker and
Can you
what
hear
if we just,
headset?
what if we just pass the headset along, the handset?
That wouldn't do it. It would be the whole connection. So can you hear us fine right now?
I can hear you over the phone, yes. Let's do a quick test. I'm going to bring audio back up online, and let's do a quick test. So just say you're testing the connection. If you can hear me, have them respond in the chat box really quickly, okay? I'm going to bring it up starting now.
Okay, well, we're testing the sound right now, everybody, so let me know if you can hear us okay.
Okay,
Got a
we got
yes?
one yes. How about some no's? Is there some no's out there? I mean,
I can hear you now.
obviously, if
Everybody
you
is
can-
everybody
if
is
you
saying better, yes, everything's
it-
good.
can- Okay.
Okay.
I mean, obviously, if there's no sound at all, you can't say no.
Okay,
But if
let's go on.
there's any poor sound, let us know.
Yeah, we are on.
Oh, okay.
Yeah, let's proceed.
Okay, we're going to go.
All right.
But thanks for the
So,
feedback.
Just go ahead.
Reminding others of a patient's key aspiration and obstacle solves the problems of identification, reminds teams what we're working for and what stands in the way. We can concern others with what diseases the person has and what person has the diseases. Stating an aspiration and obstacle sets up a dramatic tension that draws us into the story as participants. Will the patient achieve his or her aspiration? And what will the treatment team do to help?
This is yours, Carole.
Okay, so during professional meetings, listen actively and appreciate differences. Now, this can sometimes be easier said than done. So these two techniques, active listening and appreciating differences on your team, will help you understand other team members' assessments and treatment proposals, and thereby create an overall treatment plan that no one person could design or deliver on their own. This also helps that knowing that your team members, that your team and the members are both willing and effective allows you to remain humanistic with your complex patients who would otherwise seem overwhelming.
All right. Number 7 is know your colleagues as people. So again, working with a team, it's not so much a team if you don't know anything about your colleagues. So the better you know your colleagues, the better you can see their points of view and the better you can understand their assessments and treatment proposals. So we recommend trying this on Monday mornings. Check in with some of your team members by asking them about their weekend. I'm sure many of you do this already. This will help you to know them better. Especially try doing it with those that you don't talk with much or that you don't like as well.
That might be a way to get to know them. And you all know who they are on your team. And you probably have no problem asking on Monday mornings the team members you really enjoy working with. But ask those ones that are shy or that you haven't had a lot in common with.
This may seem stilted, but we do it all the time, even though it's on the Pocket Tool, and it's fun. All right, now go back to the patient you thought of in exercise 1, the one that triggered an emotional response to you. Triggered in you an emotional response to them, even though you kept it private, probably. How would you use the Humanism Pocket Tool to manage the emotion you experienced? In one sentence, describe your patient using a vivid vignette. If you like, type it in the chat window. Now, you may not have all the detail you need for this. You might even want to think about how you would use the Pocket Tool to manage or prevent such a similar situation in the future. We just want you to think about the Pocket Tool and the kinds of situations you've encountered. Take a few minutes to do that. All right, we're back looking at a variety of responses. One we just got here, client wants to create art and play music, but is experiencing homelessness and enduring an abusive relationship with family.
That's great.
I want to address something somebody just wrote. Couple of things. Just do a trauma-informed training yourself. I think there was one up there that said this seems to be a very basic level. I want to point out that it's called the Pocket Tool for a reason. We're a training program. We've got 35 trainees from multiple different professions, and we want to be able to, and some of them are here only for brief periods. We want to convey a few essential techniques that everyone must know. These are the basic techniques. That's why it seems like at a basic level. But a lot of people do not have the basic skills. Judging from this group's responses to the first 3 questions, you likely do have the basic skills. So I'm not surprised that some people write it and say, this is at a basic level. This is not the Humanism entire worksheet. This is just the Humanism Pocket Tool, the one tiny tool you take with you and share with people who are new to dealing with vulnerable patients. Here's another one. 50-year-old homeless man who is looking for affordable housing with CHF and challenges with authority and accountability. All right.
Well, it doesn't say what is that.
Yeah, that's affordable housing. Yeah. It's sort of a given with respect to housing. We try to go a little bit beyond that. They're all generally looking for housing, not all of them. Mm-hmm. But we want to know if they had housing, what then? All right.
But that is, Gwendolyn, that is exactly where we're at sometimes with the patients early on. They can't really think beyond, getting someplace to stay, and that's quite, normal in the, situation they're in the beginning as they're looking to not be homeless anymore.
And the vivid vignette evolves.
It does, right?
As they become more stable.
It's a challenge to have them think bigger picture.
All right, so that is a summary of the card. You can get more of these cards, our paper, and the manual in several ways. On the screen, there are links to the little paper that we wrote about it, and it on that Society for General Internal Medicine, I believe. No, for
Annals of Family Medicine.
Annals of Family Medicine also includes additional materials, including the full manual, which goes into this pocket tool in considerably more detail. The conceptual framework, a number of case examples, more details on the techniques themselves. It is still under construction, and we are actively looking for additional people to collaborate with. So if you have an interest there, let us know. And then in this resources box, you can go directly to a PDF of the manual, a PDF of the paper, and the pocket tool itself. And of course, you can write us with the number of cards you need and your mailing address, and we can supply you with them. What are you pointing out there?
I'm not sure we answered all the questions. The ACEs question?
Yeah. Andrea, you want to tell us more about your question? How much of your toolkit is based on ACEs? Well, you'd have to talk and write. That's not going to be so easy. While you're thinking about that, I want to read this one. 50-something social butterfly who desires to encourage people in recovery, but struggles with cocaine addiction that alters his behavior. I like that one.
Yeah. You probably get to this.
Cheryl says, you'll probably get to this, but is it okay to use this to train those new to dealing with vulnerable populations? Yeah, absolutely. That's what it's designed for.
And we've been getting requests for the HPT from a variety of different programs and audiences, including the hospitalists, emergency room departments. Andrew, where else have we been getting them? Other kinds of training programs who are dealing with complex patients.
Yeah, social workers working with the library system in Hawaii, where librarians often work with homeless veterans, and they want to help them. Those librarians want to know how to deal with not just homeless veterans, homeless people.
Where do we submit requests for a printed copy of the pocket tool?
Yeah, on the card and elsewhere, if you just write to me, andrew.shaner@va.gov.
All right, Sutton King wrote, New York Indian Council here, NYC Urban Indian Health Program. We would love to be sent this tool as we work with American Indian and Alaskan Natives. We would be happy to send you some.
Yeah, I would rather you not write the requests in there because I won't have a way of tracking whether I've seen them all, and it's scrolling past us. So send an email to me, please.
So the next question is, has this been introduced to residency programs? Yes. In fact, we've given a full session to a general family medicine training program. We use it in our own interprofessional residency training program. And if you would like it for your residency program, just contact us. And if you click on these, the web links and the resources, it will list on the back of the pocket tool how you can email Andrew.
I think there's a few more questions on this slide. Hang on. What we're interested in is how can we make the techniques even more time efficient? What other techniques do experienced clinicians use when they experience strong emotions in response to a patient? here's a question we often get. What if the clinician works primarily alone without team members? How could they use the pocket tool?
So Cheryl
Oh, and that's
asked,
what Cheryl just asked
what kind
something.
of collaboration do you need?
Yeah. Well, this teamwork is, we think, a very important component, and yet many people are working relatively alone with populations like this. When I go see a patient in our lobby here in this clinic, the experience is completely different than when I was treating patients in a general psychiatry clinic, because I know I have an entire team working with me, and I'm happy to have the patient bring up all kinds of problems. I want to hear them all because I have people to work on those problems. If I'm working alone, all that can be extremely overwhelming. I mean, I've got to focus on the one thing I have some expertise in and hope somebody somewhere takes care of those other problems.
I think what they're also asking is what kind of collaboration do we need in developing the HPT?
Oh, okay. That's different. Thank you for clarifying, Lillian. Well, we're just looking for people who, would want to take the card into their arena, try it out, and provide ideas and feedback. And it's called version 5.4 at this moment because we update it. When we learn new things and we get new ideas, we want to make it clear or substitute other techniques and so forth. The collaborations go in a variety of different directions.
We choose trainees in our interprofessional residency that really have an interest in underserved or vulnerable populations. And just having that interest is not enough, right? You need the skills in order not to burn out. And really what we want to do is impart some skills and practice these ourselves. And we looked into our own practices and those of the nurses and clerks and others in our team to see what they do in order to not just survive but thrive in a work environment they want to stay in.
So Gian Densig asked, can you speak about how knowing a person's own limits when dealing with the frustration of a client, like clients being racist or attacking worker verbally, also being kind to ourselves when we weren't able to tolerate hard emotions at times? Great questions.
Yeah, I like that question. It speaks to the variability in what people can tolerate. It also speaks to the variability in what a program will tolerate. It probably is addressed best by teamwork issues. This card draws on techniques from a variety of different domains, and the one, the teamwork one about listening actively and appreciating differences is just one of a large set of tools designed to help a team work effectively together. But you can imagine a situation where one particular person on a team is more sensitive to verbal attacks from patients than are other members. And it's very important for the team to know that about that person, to be supportive, to make changes that, make it possible for that person to continue to work effectively and to feel supported by the rest of the team. I don't know exactly that we have faced that challenge here, so I don't know that I can give specifics about it.
Well, we did in our team meeting.
You're thinking of, yeah, I was thinking about that situation as well. We did have a meeting recently with something very close to that. Someone who is fairly new to us and we think might actually have been traumatized herself. And she brought up a situation where she was quite scared about a patient, and we noted the team being quite supportive, probably making sure she understood that we all took it very seriously, even though most of us would not have responded with as much fear as she did.
Can you expand this one?
Okay.
So sometimes when I'm working, this is Carole, sometimes when I'm working with trainees, I'll notice that they're not used to our patient population and they may all of a sudden become quiet or start focusing on their computer. And after the session is over, will debrief, and I'll ask them, I noticed that you were having trouble listening, and what was going on. It kind of opens up a discussion and allows the trainees to identify the emotions that these patients can bring up. I mean, this certainly isn't part of the pocket tool. I mean, the skills you use to debrief, but I think just noting whether the trainees can actually do the skills on the pocket tool can be helpful.
Anne says, I love the idea of changing the language around the way we speak about vulnerable patients, especially in training. I think one of the worst things I learned in training was the term train wreck.
Yeah. Or Gomer. I hate that word.
Or some are even more subtle, like psychiatry trainees are fond of saying he's back at his baseline, right? And I'm thinking, what the heck does that mean? It means terrible things. Yes, the active psychotic symptoms are gone. He's still miserable. He has no social skills, but we're not going to think about that or do anything further about it because he's back at his baseline. I have no idea in what way that is helpful, except as an excuse to discharge somebody in a summary kind of way.
Yeah, and like you said, Anne, it's not just a train wreck. These are human beings, and so, really looking at that, instead of same patient, different name, we're humanizing them again and trying to get away from just summarily dismissing the patients as train wrecks or gomes or crazy or that sort of thing.
I don't know how many of you are writing progress notes, but we were particularly interested in an approach that would allow you, in just a few words, to co-opt the standard identifying string in a progress note so that you influence not only the team around you, but other teams that might encounter your patient. So we're imagining that the patient who we know a lot about ends up in the emergency room at some point. We don't want them just saying, oh no, so-and-so again, that another meth addict, right? He's always in here. We want them to see our progress note and read, studying to be a pastor but haunted by an Iraqi torture chamber, and think, what? What is that about? Studying to be a pastor? This guy? What do they mean, Iraqi torture chamber? We want this to sound like almost like a movie pitch. Something is happening here. There's a story that you need to know more about. And we're hoping that might change the kind of care somebody gets outside of our team.
So the other thing we have done is we have case conferences once a week on a particularly complex patient. And in the checklist for writing up that case conference, we've actually included the vivid vignette so that, the trainees are cued to incorporate that into their practice.
And and the regular clinicians as well.
Yes, that's right. Us too, we do forget.
Going back to that collaboration question, we're particularly interested in testing the tool in other environments. I mean, people self-select to be in our clinic, and you all self-selected to come listen to this talk, but we're interested in a team that, thinks differently, maybe a stressed emergency room staff that, doesn't practice hardly any of these techniques, and we want to see if the tool could be useful in among a challenging group of clinicians. Mm-hmm. So if you, hey, somebody just wrote that in. So often the ER staff labels patients as drug-seeking or malingering.
Yeah, we have been thinking about doing an in-service for our emergency room on this and talking more about it, and they seem to be open to that.
Mm-hmm. Well, also, I think it when we hear that, it kind of opens up the door for our compassion with our ER colleagues. They do see a lot of challenging patients and are expected to manage them in a quick, expedient way to get them in and out. So, they do have a challenging job. So
Okay, so Stephanie says, was the Pocket Tool developed with any input from clients or veterans? I'm curious whether any feedback was gathered from clients regarding the language and behaviors they hope for in a therapeutic relationship.
Good question.
Good question.
You know, I wouldn't say in quite that organized fashion, but this thing began as an attempt to know who we were talking about. And then it expanded from there to additional techniques. And each of us was working with patients and explaining what we do and what the responses of our patients were. I would say the most consistent thing was that when we clarified this notion of a vivid vignette, the very consistent response from us and from our collaborators in different cities was that doing that deliberately with a patient seemed to mark a turning point in that the patients themselves said, this is really useful. I like this. But, you know, whether, I mean, some things are sort of obvious. Being warm, I don't think anybody would argue with that. Any patients are going to say, on average, that, you know, we shouldn't be warm. But we didn't really develop it in that kind of systematic way Stephanie is talking about. But it would be useful to gather that information and find out what they think about it. We did in our program measure for a while whether patients, we used a scale, the I-CARE scale, to assess the degree to which patients thought our faculty and our trainees were being humanistic, and compassionate. And the scores were very high. There was kind of a ceiling effect on that
We
scale.
stopped measuring them because we reached the gold definition of compassionate care, the I-CARE. We reached it, so we just stopped.
But we'd like to go to in a setting where the current patients don't think the providers are very compassionate. You know, show them the Humanism Pocket Tool and measure again. That's what we're interested in doing.
Mm-hmm. Yeah, one of our trainees who was here as a nurse practitioner student and then as a first-year NP resident is a veteran, and he was one of the quickest adopters of it, and he really utilized it very well to develop rapport quickly with veterans. Huh? Oh, King Joe. Yeah, King Joe, a veteran treating veterans using the Humanism Pocket Tool.
Oh, we're at the top of the hour, Hannah.
Yeah, hi, this is Caroline again. We have just a few minutes left. We do have time, I think, for maybe one more question. I did want to return to a question that we got from Andrea, who was curious about whether you all used any knowledge of adverse childhood experiences while putting this tool together.
Well, all in our interview instruments, we're always gathering information about adverse childhood experiences. I mean, I know the psychiatrists and psychologists are, but I don't know that it directly informed the tool itself. I don't know if that answers your question, Andrea, but be happy to see your chat if you want more than that. I mean, obviously, it's very important. Earlier, there was someone who said, you know, just do trauma-informed, train everybody in trauma-informed interviewing, because trauma plays such a crucial role in causing people to behave in ways that cause other people to be anything but compassionate.
Great, thank you, Andrew. And since we are now at the top of the hour, we will log any remaining questions and pass those on to the presenters for written responses. Andrew, Lillian, Kristin, and Carole, thank you so much for presenting today. For our attendees, thank you for being present with us on this webinar. Please note that Andrew's email information is available on this slide here if you'd like to get in touch directly. Presentation materials and a link of the archived webinar will be available on our website, www.nhchc.org, within 3 business days. And a survey for evaluating today's presentation will open in your browser at the close of this session. We very much appreciate your time today. Thank you for attending, and the webinar is now closed.